healthy heart rhythm. If this is the kind of clinical information you have been missing, real science, specific numbers, and the information your doctor should have explained when prescribing your medication, subscribe right now. Every week I publish videos like this one. Peer-reviewed science translated into language that actually helps you make better decisions about your health. The subscribe button is right there. It costs you nothing and it may save you everything. You have done it. I know you have because nearly every patient I have ever treated has done it at least once. You forget your morning pill. You remember at 2 o'clock in the afternoon during dinner or just before going to bed, and the instinct is, I'll just take two tonight to make up for it. Pause. For some medications, this is relatively low risk. For others, it can trigger a cardiovascular emergency. Here's what happens inside your body when you double a dose of a calcium channel blocker or a long-acting ARB. Medications such as Vilartine or Artine, think of your arterial system as a network of flexible tubes under constant pressure. These medications work by relaxing the muscular walls of those tubes, reducing resistance and lowering blood pressure. One dose does this gradually and safely. Two doses at once can create a sudden and steep reduction in vascular resistance. Blood pressure drops sharply. In a younger adult with elastic arteries, the body often compensates. In an adult over 65 with reduced vascular tone and possibly some degree of coronary artery disease, that sudden drop in blood pressure can cause syncope, fainting, and in some cases ischemia, insufficient blood flow to the heart or brain. The second version of this mistake is quieter, but just as dangerous. Patients who are prescribed twice daily medications begin taking them only once daily because it is easier to remember without informing their physician. The blood pressure appears partially controlled. The doctor sees acceptable numbers, but the twice daily protection the medication was designed to provide is operating at only half capacity. Cardiovascular events that could have been prevented are not. Researchers at Johns Hopkins University tracked 8,211 patients with hypertension over 5 years. Those with documented dose doubling events after missed doses had a 38% higher incidence of emergency hypertensive crises compared to those who maintained consistent single dosing. Patients who inconsistently took twice daily medications had a 26% higher rate of cardiovascular hospitalization compared to patients who remain compliant with their prescribed twice daily regimen. Dennis M., age 66, a contractor from Denver, Colorado, had been taking amlopin and Vilartine for 4 years. He worked irregular hours. His mornings were unpredictable. Over time, he developed a habit of taking 2 pills in the evening whenever he remembered that he had missed his morning dose. He came to me after his wife found him unconscious on the kitchen floor. His blood pressure had dropped to 79/48, no heart attack, no stroke, just a preventable double-dose episode. Pause. The protocol is clear and non-negotiable. If you miss a dose and remember later that same day, take it as soon as you remember, unless your next scheduled dose is less than 4 hours away. If it is close to your next dose time, skip the missed dose completely and return to your normal schedule. Never double a dose without first calling your pharmacist because the correct answer depends entirely on the specific medication you are taking. Synergy tip. Set a daily phone alarm labeled with the name of your medication. Link it to a specific daily anchor, such as your first meal or brushing your teeth. According to a 2019 UCLA medication adherence study, behavioral pairing reduced missed doses by 63%. We have now arrived at number 1, and I want you to hear this carefully because this is not a minor optimization. This is not a simple lifestyle adjustment. This is a fundamental misalignment between how most blood pressure prescriptions are written and what the science actually shows. Pause. For decades, for my entire career, and for most of the careers of the physicians currently treating you, the default instruction on blood pressure medication has been take once daily in the morning. It was a convention born in an era before we understood circadian biology well enough to question it. Today, we understand it very well, and the evidence is unambiguous. Your blood pressure follows a biological rhythm as precise as a clock. During sleep, it falls. In the early morning hours, typically between 4 and 10 a.m., it rises sharply as cortisol levels increase. The sympathetic nervous system activates and your body prepares for the demands of the day. This morning surge is the single most dangerous cardiovascular window in a 24-hour period. It is when the majority of heart attacks and strokes occur. Now, think about what a morning dose actually does. You take your medication at 7 or 8 o'clock in the morning. It absorbs over the next 1 to 2 hours. It reaches peak blood concentration around 9 or 10 a.m., just as the morning surge is already subsiding. By 4 or 5 the following morning, when the next surge is building again, the medication has been declining in concentration for 18 to 20 hours. The window during which you need the most protection is precisely when your medication is at its weakest. A bedtime dose changes everything. Take your medication at 10 p.m. By 4 a.m., it is at or near peak concentration. It is fully active during the morning surge. The surge meets a pharmaceutical wall. Your arteries are protected at exactly the moment they are most vulnerable. This is not speculation. The Haya chronotherapy trial, the largest study ever conducted on blood pressure medication timing, enrolled 19,840 Spanish adults with confirmed hypertension. Half of the participants took their antihypertensive medication at bedtime. The other half took it in the morning. After a median follow-up period of 6.3 years, the bedtime group demonstrated a 45% reduction in cardiovascular death, heart attack, heart failure, and stroke compared with the morning dose group, 45%. That is not a small effect. That is the kind of number that should appear directly on the prescription label. A 2022 meta-analysis published in the Journal of the American Heart Association reviewed 11 randomized control trials involving 21,400 patients. The analysis found consistent evidence that evening dosing of ACCE inhibitors and ARBs produced superior nocturnal blood pressure control, better suppression of the morning blood pressure surge, and meaningfully improved long-term cardiovascular outcomes. The authors concluded that clinicians should consider individualized dosing schedules based on each patient's circadian blood pressure pattern. Eleanor F., age 79, a retired opera singer from Chicago, Illinois, had been taking lisinopril for 11 years. She took it every morning at 8 a.m. Her blood pressure appeared controlled on paper, her office readings were acceptable, but when her cardiologist ordered a 24-hour ambulatory blood pressure monitor, the data revealed a very different story. Her blood pressure surged to 162/94 between 5 and 7 o'clock every morning. She was, as I often tell my patients, controlled at the wrong time of day. We switched her medication to bedtime dosing. 3 months later, her ambulatory monitoring showed complete suppression of the morning surge. Her cardiologist told her that her cardiovascular data looked better than it had in more than a decade. Eleanor told me, "I wish someone had told me this 11 years ago." There is an important caveat I owe you. The Haya chronotherapy trial has been questioned on methodological grounds by some researchers. Several subsequent studies, including the Time trial in the United Kingdom, involving 21,114 patients, did not find a statistically significant difference between morning and bedtime dosing in cardiovascular outcomes. The science is not fully settled. What is settled is this: bedtime dosing has not been shown to be harmful, and for many patients with non-dipping blood pressure patterns, it may offer substantial benefit. The only way to know whether you are one of those patients is to ask your physician for a 24-hour ambulatory blood pressure monitor. That test tells the full story of your circadian blood pressure pattern, and it is the single most powerful tool available for personalizing the timing of your antihypertensive medication. Here is the most important action item from this entire video. At your next appointment, ask your doctor one simple question: should I be taking my blood pressure medication at bedtime instead of in the morning? And then ask, would an ambulatory blood pressure monitor help us decide? That one question may be worth more than anything I could prescribe through a screen. Synergy tip: if you switch to bedtime dosing, take your medication 30 minutes before you lie down, not after you are already in bed. This allows proper initial absorption. Pair it with a consistent bedtime routine. The consistency of timing matters just as much as the timing itself. Melatonin secretion typically peaks around 10 p.m. and may provide a natural physiological ally for medication absorption during the overnight period. I want to speak to you directly for a moment, not as a patient, not as a viewer, but as a person, because everyone watching this is managing something, a prescription they have been taking for years, a concern they carry quietly, a body that does not always behave the way it once did. Here is what I want you to remember. The fact that blood pressure medications exist, that we can chemically intervene in one of the body's most essential biological rhythms and reduce the risk of stroke and heart attack by 30, 40, or even 45% is one of the genuine achievements of modern medicine. You are not failing because you take medication. You are using a tool. And like any tool, how you use it matters just as much as whether you use it at all. Aging is a biological process. Some aspects of it are inevitable, but the morning surge your arteries face each day, the timing windows your medication needs to cover, and the interactions hidden in your grapefruit juice or morning coffee, these are not destiny. They are variables. And variables can be managed with knowledge. Pause. This channel exists because I believe every person has the right to make informed decisions about their own body. The dignity that comes from understanding your health is not a privilege. It is something you deserve at 60, at 70, at 80, and beyond. So here's my question for you today. Which of these five mistakes surprised you the most? And which one will you take action on before your next dose? Tell me in the comments below and tell me your age. Your experience may be exactly the insight another viewer needs. If this video gave you something valuable, something your last appointment did not, subscribe to this channel. Every week I publish videos like this one, peer-reviewed science, specific numbers, real clinical context, practical information for adults over 60 who deserve honest evidence-based guidance about their health. I'm Dr. William Li. I've spent 35 years in medicine, and this is the conversation that should have happened in the exam room. Pause.